So urinary MRD is very interesting. It has kind of emerged over the last few years as a way to essentially use next generation sequencing to look at alterations in what's present in the urine, with the idea being that potentially assessing these mutations can provide a signal as to whether or not somebody might be responsive to treatment, or potentially point signs as to how aggressive their disease is. One of the kind of overarching hypotheses that we have is that when we classify patients as being CIS or papillary disease only, to some extent these are very crude classifications, and there's a lot of heterogeneity within each group of the biology of the behavior of those tumors. And that's likely why, if you look at all these different drugs that are being evaluated, there's a lot of the patients, the kind of the 1 year efficacy mark tends to be kind of hovers around 25% or so. And so it's likely that there are some patients that are have very aggressive disease and some patients have less aggressive disease. So urinary MRD is potentially a way to assess or stratify these patients. So what we did in our assessment was we took the phase 2 trial of Nadofaragene. So this is not the phase 3 trial, but the phase 2 trial. So it's much smaller cohorts, about 35 patients. And what we did was we had urine from 2 time points: before they got the therapy and at the 3-month assessment time point. And we assessed urinary molecular minimal residual disease at that first time point and at that 3-month time point, and essentially looked to see, could the MRD status predict 12-month recurrence-free survival? So we had data, of course, on how these patients recurred or didn't recur, and what we found was both the pre and post 3-month urines were highly predictive of 12-month recurrence-free survival. Actually, the post induction 3-month urine, if you were MRD negative, it was 100% predictive of a 12-month recurrence-free survival. In the pre-treatment urine, it was around more like 70%. Now, this is a small study. The caveats are that only 35 patients were essentially evaluated with urine. And so we look forward to further validating this using urine from the phase 3 study. That work is underway. I think the way we would potentially use this in the future, pending validation, is to help assess response to therapy. So you could see potentially 2 strategies. One could be, as you're looking at all of these different drugs that are available, you could potentially see a future where you do urinary testing, and then depending on their MRD status, you could recommend certain types of treatment for them, whether that means cystectomy, removal of the bladder, or one of these agents. Another way you could use it is to as a kind of an adjunct for response to therapy. So currently, the way we assess response to therapy is with a cystoscopy and with urine cytology. Cytology has kind of become the gold standard, but there's a number of flaws with urine cytology. There's a lot of inter-assessor reliability, if you will, from the pathologists who are looking at it. It can also vary from person to person depending on how it's collected. And so, something like a urinary MRD test, again, with validation, could potentially be used to help patients and the doctors that care for them kind of know, hey, you're doing well with this therapy, or maybe you're not. And so that's kind of where we're headed with that. For our patients, it's a really exciting time in the sense that, obviously there's never a good time to have any kind of cancer, certainly not non-muscle invasive bladder cancer. But for a very, very long time, certainly when I was a resident, I felt like there were so few options for our patients. I felt like we were either just giving BCG or telling our patients they needed their bladder removed. And that's one of the reasons I got involved in bladder cancer research, why my practice is focused on the management of bladder cancer. So, at the AUA this year, while there's a lot of new questions that we have about which treatments to give and which one works the best, I think these are good problems to have. And what's heartwarming for me is the fact that we now have so many more options to discuss with our patients than we previously did. So I think it's, from that perspective, it's an exciting time. And, I think it's going to be a really close area to follow over the next few years as we kind of figure this out for our patients.